Hello, welcome to BME 107, Mental Disorders. We're going to be talking about mood and bipolar disorders in this presentation. So the first thing we want to talk about is the concept of depressive disorders. Depressive disorders are prolonged and disturbed emotional states that affect almost all of a person's thoughts, feelings, and behaviors. There are 6 types of depressive disorders that we'll be discussing in this PowerPoint. Major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, disruptive mood dysregulation disorder, substance/medication-induced depressive disorder, and depressive disorder due to another medical condition. And just to kind of demonstrate the link between neuroscience and depression, I have a picture on the right-hand side of this slide that demonstrates the difference in a normal brain versus a brain that's suffering from depression. And you'll see the electrical impulses are severely dulled in a brain that is for a person who's suffering from depression. So let's talk about major depressive disorder first. It is a medical illness that affects how you feel, think, and behave, causing persistent feelings of sadness and loss of interest in previously enjoyed activities. Depression can lead to a variety of emotional and physical problems. It is a chronic illness that usually requires long-term treatment. That is a very important aspect. This is not feeling bummed out for a few days because something happened with your love muffin. This is a chronic, long-term problem. A lot of us feel depressed when we have a death in the family, whether it is a parent, a sibling, a good friend. And in grief, painful feelings come in waves, often intermixed with positive memories of the deceased. However, in depression, mood and ideation are almost constantly negative. In a sense, it's like wearing sunglasses that take everything and put a negative filter on it. So no matter what you're doing or seeing, it's got a negative perspective on it. In grief, our self-esteem is preserved. We have a sense of ourselves as a realistic understanding, whereas in major depressive disorder, we have these corrosive feelings of worthlessness and self-loathing, which is part of our feelings of depression. The triggers for depression, especially major depressive disorder, include the death of a loved one, losing one's job, especially if you identify closely to that job. So, for example, if you are a social worker and you feel very identified with the job that you do, or a teacher or a nurse, and you lose your job, you lose part of your identity. And that has a huge trigger of becoming depressed. Being the victim of a physical assault, surviving a major disaster, financial problems, having a poor diet. If you eat really terrible food all the time, your ability to metabolize and move through your day is going to have problems because you're not treating yourself well. Alcohol abuse, poor sleep habits, and something that a lot of women can understand, which is stress from overcommitting. Having overcommitting at work, overcommitting at home, overcommitting with your family. And this tendency can trigger major depressive disorder, which is very emblematic of what women tend to do on a regular basis. The diagnostic criteria for major depressive disorder includes a depressed mood or a loss of interest or pleasure in daily activities for more than 2 weeks. Mood represents a change from the person's baseline. So let's say that you're just kind of a cranky person in general, but now you're a super cranky person. So instead of just being like just a generally cranky, now you're miserable. So it's not that you are a cheerful person all the time, it's you're really going downhill. Additionally, you have impaired function in your social, occupational, and educational worlds. Plus, you have at least 5 of the following symptoms, which are present nearly every day. Depressed mood or irritable most of the day, nearly every day, as indicated by either subjective report, meaning you feel sad or empty, or observations made by others. So your friends or family say, "Are you okay? You look like you're really sad." Decreased interest or pleasure in most activities most of the day. Significant weight change, more than 5%, or a change in appetite. The change in your sleep pattern. Either you can't sleep or all you want to do is sleep, which is known as hypersomnia. Change in activity. Psychomotor agitation or retardation, meaning you're either really hyper or you just sit on the couch like a vegetable and stare at the TV, which can be fun in and of itself, but you can't do that 7 days a week. Fatigue or loss of energy, guilt and worthlessness, feeling inappropriately guilty. It's one thing to feel bad that you didn't call your mom on her birthday, which you should feel bad. But feeling guilty that, little things. Concentration, diminished ability to think or concentrate, being more indecisive than usual. And then thoughts of suicide or how you think of dying or having a suicide plan. These symptoms, taken together, 5 of them, really do represent a person whose mood has gone to that pit of despair. Levels of functional impairment for major depressive disorder. So we have moderately impaired versus severely impaired. Family relationships, moderately impaired, you're quiet, you're negative. But when you're severely impaired, you're very withdrawn, you're angry, you won't talk, you're aggressive. In school, your grades, your work performance are deteriorating when you're moderately impaired. But when you're severely impaired, you fail, you miss school, you don't care anymore. You become oppositional. Peer relationships, when you're moderately impaired, you decrease your socializing, you spend more time on the computer. When you're severely impaired, you isolate yourself. You discontinue all social activities, and you spend all of your time on the computer. And this isn't about spending time engaging in social media. This is going down the rabbit hole of the dark recesses of the internet, where you can go on sites where you discuss how to commit suicide or the best ways to cut yourself or how to commit suicide in ways that your family will feel really bad about it. Horrible sites. If you're moderately impaired, you deny your issues and you project the blame onto others. But if you're severely impaired, you don't talk about anything. When you're moderately impaired, you have kind of a vague idea of suicide. But when you're severely impaired, you have a plan. You consider it. You've attempted it. And then when you are moderately impaired, you think about self-harm, but you haven't really made an attempt. On the other hand, when you're severely impaired, you maybe engage in cutting, engage in some other self-harm, bulimia, pulling your hair out, excoriation, where you're literally ripping skin off your fingernails. So these kinds of identifiers really do indicate the level of depression a person is suffering from. Then we move into persistent depressive disorder, which is also a chronic type of depression, which is depression, but it's not as severe as the major depression. So the symptoms come and go, but their intensity changes over time. It's kind of a low-grade depression. If you think of it in terms of a fever, major depressive disorder is like 103 fever. Persistent depressive disorder is 100 or a 99-degree fever. So its effects, especially after a couple years, can have a significant impact on one's quality of life. Because ultimately, what it does is you begin to withdraw. And that withdrawal includes, lacking enthusiasm, lacking energy, lacking an appetite for life. And, ultimately, it can, in fact, have as much an impact on your life as major depressive disorder. Symptoms of persistent depressive disorder, and again, you're going to see a lot of the same types of symptoms, and this is one of the issues in diagnosing these issues, is that the symptomology overlaps. So you do tend to see symptoms that are so similar that people are misdiagnosed, and it often takes a few years to get a correct diagnosis. And it's not because the psychiatrist or psychologist is an idiot. It's because it might take a few years to assess based on the trajectory of the illness. So the symptoms: loss of interest in daily activities, sadness or emptiness, hopelessness, tiredness, lack of energy, low self-esteem, high levels of self-criticism, feeling incapable, trouble concentrating, trouble making decisions, irritability, excessive anger, decreased activity, effectiveness, and productivity, avoiding social activities, feelings of guilt and worries over the past, poor appetite or overeating, and sleep problems. Notice you do not see suicide as an element in persistent depressive disorder. So I have a picture of Eeyore over here, and for those of you who are familiar with the Winnie the Pooh stories, Eeyore is kind of a good example of a persistent depressive disorder. He's not, going to jump off a cliff, but he's sad a lot, and he needs a lot of support from his friends, but he's always willing to show up. He just needs to be encouraged a lot. The risk factors associated with persistent depressive disorder include the fact that it begins early. It's something that starts in childhood, and you see it in the teen years, young adult, and it's chronic. It probably goes on through your entire life. Certain factors appear to increase the risk of developing or triggering this disorder. Having a first-degree relative with a major depressive disorder or other depressive disorder. So if your mom or dad have a depressive disorder, you might develop persistent depressive disorder. Traumatic or stressful life events such as the loss of a loved one or financial problems, so again a trigger. Personality traits that include negativity such as low self-esteem and being too dependent, too self-critical or pessimistic. And then a history of other mental health disorders such as a personality disorder or anxiety. So, these kinds of disorders are not just about a person unable to see the bright side of life. These are issues that have a genetic component as well. Then we're moving on to premenstrual dysphoric disorder. It is not the same thing as PMS. Premenstrual Dysphoric Disorder is a condition in which a woman has severe depression symptoms, irritability, and tension before menstruation. These symptoms are way more severe than what you see with PMS or premenstrual syndrome. It refers to a wide range of physical or emotional symptoms that typically occur 5 to 11 days before a woman starts her monthly menstrual cycle. The symptoms usually stop when or shortly after her period begins. So, what causes PMDD? Hormone changes that occur during a woman's menstrual cycle may play a role. Birth control pills typically help reduce PMS symptoms, and continuous dosing types are most effective, especially those that contain a hormone called drostoropane. Other factors that may play a role include alcohol or substance abuse, thyroid disorders, being overweight, having a mother with a history of this disorder, and lack of exercise. Symptoms of PMDD include lack of interest in daily activities and relationships, fatigue or low energy, sadness, hopelessness, possible thoughts of suicide, anxiety, feeling out of control, food cravings or binge eating, mood swings with bouts of crying, panic attacks, irritability or anger that affects other people, bloating, breast tenderness, headaches, joint or muscle pain, problems sleeping, and trouble concentrating. Now, what separates this from a major depressive disorder is this only lasts a few days each month. And for women who are suffering from something of this nature, it is real, it is significant, and when people minimize it, it becomes a true problem for the relationship that the two people are engaged in. The next disorder we're going to talk about is disruptive mood dysregulation disorder. This was recently added to the DSM-5, so it was not in the DSM-4. It is diagnosed in children. The onset of symptoms must be before age 10, and a DMDD diagnosis should not be made for the first time before age 6 or after age 18. DMDD goes beyond describing temperamental children to those with a severe impairment that requires clinical attention. So, when your 8-year-olds had too much sugar and they're running around the house making you crazy, that's normal. This is much more severe. It is characterized by severe and recurrent temper outbursts that are grossly out of proportion in intensity or duration to the situation. These occur, on average, 3 or more times each week for 1 year or more. Between outbursts, children with DMDD display a persistently irritable or angry mood most of the day and nearly every day that is observable by parents, teachers, and peers. A diagnosis requires the above symptoms to be present in at least 2 settings, at home, at school, or with peers, for 12 or more months, and symptoms must be severe in at least one of these settings. During this period, the child must not have gone 3 or more consecutive months without symptoms. So, these kids are literally little dictators who run their homes using anger and temper tantrums as their power, as their weapon. When we treat DMDD, there are 2 major types of treatments that are used. The first type are psychological treatments. This is the first type of treatment that should be utilized. Psychotherapy, which includes cognitive behavioral therapy, which is the most effective. It includes having the child think about why they're acting in a certain way and how they can use their thoughts to control their behavior. It also includes having their parents involved. Parent training, which includes having the parents learn more effective ways to respond to irritable behavior, especially maintaining consistent expectations and rewarding positive behavior. Computer-based training, which research has shown that kids with PMDD cannot accurately read facial expressions, and training programs help them improve this skill. Interestingly, as an aside, research has also shown that children or young people who are going through adolescence also struggle with reading facial expressions, and computer training can help them as well read facial expressions more effectively. Then we move on to medication, and I know a lot of parents are reluctant to utilize medications because they don't want their children to rely on medication to control their behavior. However, there is evidence that in children with irritability and ADHD, that stimulant medications also decrease their irritability. So when we have a kid who has ADHD and we give them Adderall or Ritalin and it improves their ability to concentrate and focus, it will also help them reduce their irritability. So in a sense, it's taking a negative behavior and a stimulant, and for some reason, this helps them focus. Then we have antidepressants, which are sometimes used, but they cause serious issues in children, often leading to suicide ideation, which means that doctors are very reluctant to prescribe these meds unless it is the very last option. Finally, atypical antipsychotics can be prescribed for children with very severe temper outbursts that involve physical aggression towards people or property. And these are used when there is a danger that they could hurt someone or hurt themselves. Substance or medication-induced depressive disorder can occur due to a person's decision to abuse an illegal substance, or it may be the result of an improper use of a medication that has been prescribed by a physician, i.e. opioid abuse. So, list of symptoms include, but are not limited to, oversleeping, listlessness, social and emotional disengagement, sadness, suicidal thoughts, fatigue, a sense of hopelessness, and irritability. So, depending on what substance they are abusing, it really will define what symptoms will be manifested. The patient with this type of disorder has to be willing to adopt a healthy lifestyle habit, because this is not a depression that comes around because they have a serotonin imbalance. This is a depression that is developed because they are misusing a illegal substance or a prescribed substance. They need to eat properly, they need to exercise, and they need to stop using that substance. This also means the individual has to develop a new set of friends, tell their family and their friends that they need help, they need to avoid that substance, and they need to oftentimes move just to get away from their environment. Men who are depressed are much more likely to mask their own symptoms with alcohol. So in some cases, it's the chicken and the egg. Is somebody using drugs and alcohol to mask their depression so they become even more depressed? Or did they become depressed because they're using drugs and alcohol? So it's a very complicated scenario when a person is utilizing these kinds of medications. Depressive disorder due to another medical condition. Certain medical conditions can lead to a state of depression, such as a brain injury, Huntington's disease, Parkinson's disease, hypothyroidism, Cushing's syndrome, stroke, and multiple sclerosis. And of course, this is much more understandable. If you know that you have a terrible disease that will ultimately lead to your death, or have terrible, you'll have a terrible life experience that will inordinately lead to a depression, which is very reasonable in this situation. So, what is the prevalence of depression disorders? In 2014, an estimated 15.7 million adults aged 18 or older in the United States had at least one major depressive episode in the past year. So this is about 6.5% of all U.S. adults, and this is from the National Institute of Health, or NIH. Women report depressive disorders almost twice as often as men. And this is not a gender issue, it is a cultural issue. And what I mean by cultural issue is that men, especially in the United States, have been raised to walk it off. You get hurt, you stand up, you man up, and you get over yourself. Whereas girls, they get hurt, they run to mommy, they get a hug, they get a kiss better, and they're allowed to be sad and upset. So men in this country have been taught that it's not okay to cry. And for that, men have learned to mask their feelings. And until men are allowed to talk about how they feel and address their sadness, you will see men continue to have higher rates of alcoholism and drug addiction in this country for the, not ongoing future. The highest rate of depressive disorders occur around ages 30 to 44, and the average age of onset is around age 30. So what causes depressive disorders? We have biological issues. People with persistent depressive disorder may have physical changes in the brains. For example, the hippocampus, which is a small part of the brain, and it's in the back of your head, that is vital to the storage of memories, appears to be smaller in some people with a history of depression than in those who've never been depressed. A smaller hippocampus means that it has fewer serotonin receptors, and serotonin is what keeps our mood balanced. So fewer receptors means fewer balancing receptors. Then we have our brain chemistry. Neurotransmitters such as serotonin, which, as I mentioned, plays a key role in keeping our mood balanced, or dopamine, are naturally occurring brain chemicals that play a role in depression. Inherited traits and people with depressive disorder appear to be more common in people whose blood relatives also have the condition. Researchers are trying to find genes that may be involved in causing depression. And the reason this is a challenge is that it's never just one gene, one chromosome. There's a multitude. And with the advent of the study of epigenetics, the influence of environment on our genes, whether or not your mom is around a certain chemical, if mom is sick while she's pregnant, if there is a certain environmental influence while mom is pregnant. All of these things can happen in the womb that can have an impact on you, that turns on genes or turns off genes. Life events, and as we talked, these are triggering events such as the loss of a loved one, financial problems, high level of stress that can trigger persistent depressive disorders in some people. Other things, abuse, physical, sexual, emotional abuse can increase the vulnerability for clinical depression later in life. Certain medications, such as drugs, like Accutane, which is used to treat acne, corticosteroids, can increase the risk of depression. Conflict. Depression in someone who has a biological vulnerability to develop depression may result from personal conflicts or disputes with family members or friends. Serious illnesses, sometimes depression coexists with a major illness or may be triggered by another medical condition. Substance abuse. Nearly 30% of people with substance abuse problems also have major or clinical depression. And again, as I mentioned before, you have the chicken and the egg issue. What came first, the depression or the substance abuse? So how do we treat depression? There's two major issues here. One, psychotherapy, cognitive behavioral therapy, which is very effective. You have to think about what helps you, what triggers you, what behaviors are involved. And then second, we have medication. And these increase the levels of specific groups of neurotransmitters. Serotonin, which balances our moods. Norepinephrine, which manages our fight or flight response. And dopamine, which manages a lot of our physical movements. And these are all involved in the regulation of our emotions and our moods. The three most popular ones are selective serotonin reuptake inhibitors, or SSRIs. The way an SSRI works is that in your brain, if you imagine it like a sponge, when your brain has a good experience or a positive experience, you get a squirt of serotonin, and it bathes your brain in serotonin, and you feel really good. You feel positive. It's like you wake up in the morning and you find out that you won $50 in the lottery. Yay! And then your brain starts to absorb that serotonin through the receptors. And the problem here is that if your brain reabsorbs the serotonin too quickly, your mood drops. However, if your brain absorbs the serotonin slowly, then your mood stays balanced. Now, the word reuptake inhibitor means that it slows the absorption rate of the serotonin, meaning that it will slow down this absorption and it'll keep your mood balanced longer. Then we have tricyclic antidepressants, which are beneficial, especially if someone is suicidal. And then serotonin and norepinephrine reuptake inhibitors, which are very similar to the SSRIs, but it also slows the absorption of norepinephrine, which again, just to remind you, is in charge of our fight or flight response. Another way they treat depression, which is not used as often but is available for people with chronic depressive disorder, is electroconvulsive therapy, or ECT. It used to be called electroshock therapy, and if you ever saw the movie or read the book One Flew Over the Cuckoo's Nest, you might remember one of the characters being subjected to this. It's not as barbaric as it is seen in the movie, and it's actually an actress named Carrie Fisher, who played Princess Leia in the Star Wars movie, has written about it in one of her books. She suffers from chronic depression and addiction issues, and she has undergone ECT several times. So she's written about it also. And it involves placing electrodes on the skull and administering a mild electric current that passes through the brain and causes a seizure. Treatment consists of 10 to 12 sessions at about 3 per week. And a serious side effect of ECT is memory loss, which is short term and usually will come back, but there are gaps. But for people who suffer from chronic major depressive disorder, this oftentimes is the best relief they can achieve. So now we're going to move on to bipolar disorder. And this was previously known as manic depression. It is a brain disorder that causes unusual and unpredictable shifts in mood, energy, activity levels, and makes it difficult to carry out normal daily tasks. It causes significant impairment in social, occupational, and general functioning, and it is defined by shifts from extremely up, i.e. elated and energized or mania, to very down, i.e. hopelessness and lethargic or depressive. It often starts in a person's late teen or early adult years, but children and older adults can also have bipolar disorder. And the illness is chronic and lasts a lifetime. There are 4 basic types of bipolar disorder: bipolar disorder 1, bipolar disorder 2, cyclothymic disorder, and other specified or unspecified bipolar and related disorders. The prevalence, although bipolar disorder can occur at any point in life, the average age of onset is 25. Every year, about 3% of the U.S. population is diagnosed with bipolar disorder, with nearly 83% of the cases being classified as severe, and it affects men and women equally. Bipolar 1 disorder is defined by manic episodes that last at least 7 days, or by manic symptoms that are so severe that the person needs immediate hospital care. At least 3 of these manic symptoms must be evident: excessively high self-esteem, has little need for sleep, speaks rapidly and frequently, has racing thoughts, is easily distracted, pursues pleasurable activities despite risks. Now, one of the issues that kind of limits these manic episodes to 7 days is number 2, little need for sleep. When somebody is going through a manic episode, they sleep very little, and our bodies absolutely need sleep. So after 3 or 4 days, the person, if they have not slept, starts to hallucinate, they start to have delusions, and by day 5 or 6, they are in almost a psychotic state. And the people who are around them, their loved ones, their family, their friends, they identify this issue and see it as a huge call that they have to get their loved one into a hospital. So usually this manic period is then followed by a period of severe depression, typically lasting at least 2 weeks, although a few individuals may not experience a major depressive episode. Episodes of depression with mixed features, having depression and manic episodes at the same time. For example, racing thoughts of mania with the listlessness of depression are also possible. Also, dysphoric mania is common, particularly in adolescence. This is mania characterized by anger and irritability. And for many of us who've had teenagers in our homes, that's pretty much what having a teenager is like a lot of times. Bipolar 2 disorder is similar to bipolar 1, but not as severe. It is defined by a pattern of major depressive episodes and hypomanic episodes, but not the full-blown manic episodes described previously. So the depression is just as bad, but the manic episodes are not. They tend to have extremely low energy, slowed mental and physical processes, and more profound fatigue. For example, hypersomnia, a sleep disorder marked by a need for excessive sleep or sleepiness when awake. 3 or more of the following symptoms will be present: inflated self-esteem or grandiosity, decreased need for sleep, more talkative. The subject will experience ideas and racing thoughts and ideas, very distracted, increase in goal-directed activity or psychomotor agitation, excessive involvement in pleasurable activities with a high potential of painful consequences, And the individual will not have experienced a manic episode or a mixed episode. So again, this hypomanic episode is not as severe as the manic episode that you would see with a bipolar 1 situation. A cyclothymic disorder is defined by numerous periods of hypomanic symptoms as well as numerous periods of depressive symptoms lasting for at least 2 years or 1 year in children and adolescents. However, the symptoms do not meet the diagnostic requirements for a hypomanic episode and a depressive episode. They tend to be much milder. So you'll see in this chart down here that mania is at the top, severe depression is at the bottom, hypomania, slight depression, and then normal. So when you are looking at bipolar 1, the loops are going to be much higher and lower, whereas with bipolar 2, these ups and downs are flatter, and when you get to cyclothymic, they're almost flattened. The issue here, though, is that the patient may develop bipolar 1 or bipolar 2 as they get older. Other specified and unspecified bipolar and related disorders are diagnosed when a person does not meet the criteria for bipolar 1, 2, or cyclothymia, but has had periods of clinically significant abnormal mood elevation. The symptoms may either not last long enough or not meet the full criteria for episodes required to diagnose bipolar 1 or 2. There is a concept called rapid cycling, which is known occurs in up to 20% of bipolar individuals. In rapid cycling, at least 4 manic and depressive mood swings must occur within 12 months. What that means is, in someone who is not rapid cycling, you may only see a manic cycle once a year. But in rapid cycling, you're seeing 4 in a year. In some cases, you have ultra rapid cycling, where the individual may bounce between manic and depressive states several times within a 24-hour period. And this condition is very hard to distinguish from mixed states because they're going up and down within 24 hours. The symptoms: mood episodes, periods of intense emotion, changes in sleep patterns, activity levels, and unusual behaviors. Sometimes a mood episode includes symptoms of both manic and depressive symptoms. This is called an episode with mixed features. People experiencing an episode with mixed features may feel sad, empty, hopeless, while at the same time feeling extremely energized. The signs of a manic episode: feeling very up, high, elated, having lots of energy, feeling increased activity levels, feeling jumpy or wired, having trouble sleeping, becoming more active than usual, talking really fast about a lot of different things, being agitated, irritable, touchy, feeling like their thoughts are going very fast, think they can do a lot of things at once, and doing very risky things. And these are the 2 things they do on a regular basis. They spend a lot of money and they have a reckless sex. So you might have somebody who is monogamous, they've never cheated on their spouse, they get into a manic episode and they are at a bar picking up someone and having sex with them in a car, and they have never done something like that before, but in that manic episode, their entire ability to make good choices goes out the window. Signs of a depressive episode: feel very sad, have very little energy, have decreased activity levels, have trouble sleeping, feel like they can't enjoy anything, feel worried and empty, have trouble concentrating, forget things a lot, eat too much or eat too little, feel tired or slow down, and think about death or suicide. So when you're looking at someone who's manic depressive, there's so many elements that go into it. It's very hard to really pin it down as to whether or not somebody is just dealing with a depressive disorder or a manic depressive or bipolar disorder, and which of the bipolar disorders they're dealing with. Hypomania is a less severe form of mania. During a hypomanic episode, an individual may feel very good, be highly productive, and function well. The person may not feel that there's anything wrong, but family and friends may recognize the mood swings and/or changes in activity levels as possible bipolar disorder. And that's the issue, is that the patient won't see it in themselves. The person, the family, the friends, they're the ones who see it. And without proper treatment, people with hypomania may develop severe mania or depression. People with bipolar disorder can live healthy and productive lives, but the first step is to seek medical assistance, and doctor will assess a patient's physical health initially before moving on to a mental health evaluation or refer the patient to a mental health professional such as a psychiatrist. People with bipolar disorder are more likely to seek help when they are depressed than when they are experiencing mania or hypomania, so patients can be misdiagnosed initially. Concurrent illnesses or comorbid illnesses. People with bipolar disorders are also at higher risk for thyroid disease, migraine headaches, heart disease, diabetes, obesity, and other physical illnesses. They are also more likely to suffer from anxiety disorders, substance abuse, especially cocaine. They love feeling manic, and eating disorders. Young people often have bipolar disorder and ADHD, which contribute to their issues staying focused. Another issue that young people often have in conjunction with bipolar is oppositional defiance disorder, which is when a young person exhibits a frequent and persistent pattern of anger, irritability, arguing, defiance, or vindictiveness towards authority figures. Some patients with severe episodes of mania or depression may have psychotic symptoms such as hallucinations or delusions, and this can result in the patient being misdiagnosed as schizophrenic. And remember, if somebody stays awake 3, 4, 5 days without any sleep, they can definitely have hallucinations. So again, misdiagnosis is a common problem, but it's about being persistent and making sure that the patient is followed up with over and over again to make sure that the diagnosis is consistently examined. So what causes bipolar disorder? And we're going to look at the brain structure first. Patients with bipolar disorder demonstrate significant reductions of whole brain and prefrontal lobe volumes, and enlargement of lateral ventricles and globus pallidus in MRI scans. Also, significant decrease of total white matter volume was found in bipolar patients. Recent research at the University of Iowa suggests that the cerebellum, which again is right back here, may function abnormally in patients with bipolar disorder, and that lithium might potentially target the cerebellum and alter glucose levels in this brain region, thereby mitigating the symptoms. So, when we look at these things and we look at the brain, it's important to remember that up until 25, 30 years ago, scientists knew very little about what the brain actually did. And every day that goes by, we learn more and more. So we're still in the infancy of research. And as we move forward in research, we're going to learn more. And as we learn more, we're going to be better able to manage these illnesses. In terms of genes, according to the Mayo Clinic, 60% of bipolar cases have a family history of the disease. The Child and Adolescent Bipolar Foundation reports that the risk for a child of one bipolar parent to develop the disorder is 15 to 30%. If both parents have bipolar disorder, the risk for each child increases to 50 to 75%. The risk in siblings and fraternal twins is 15 to 25%, whereas the risk in identical twins who share the same genes is approximately 70%. Research suggests that genetic mutations in specific regions on chromosome 13, 18, and 21 can lead to people developing bipolar disorder. So clearly the research is being done, and the more money that's being put towards science and research, the more we'll learn. So even if you're not interested ultimately in pursuing a career in these fields, how do you affect change? Well, this is when you write to your congressman, your representatives, and you say, hey, instead of spending money on this or that, let's put some more money into finding out what causes and fixes mental illness. So how do we treat it? Well, it's never cured. It is a lifelong chronic illness that has to be managed. So we can't fix it, we manage it. We manage the mood swings. The best option is a combination of medication and psychotherapy. The challenge is that when a person feels normal, they feel like they don't need their medication any longer, and consequently they stop taking their meds, which only makes their symptoms worse before they start seeking treatment again. And it becomes this cycle. And despite the fact that they generally understand that they need to take their meds, what happens is they stop taking their meds, and then they enter a manic phase where they feel awesome. They have that inflated sense of self-esteem and grandiosity. They're feeling like the world is their oyster, nothing can stop them, and then they crash. And that's when they will seek treatment. And they go through this cycle over and over again until somebody steps in from their family and says, no more, you cannot go off your medication. And then inevitably they will start hiding the fact that they go off their meds. And it is a dangerous and inevitable cycle. So, the medications that are used to treat bipolar disorder include mood stabilizers, atypical antipsychotics, and antidepressants. Mood stabilizers balance the highs and lows of mania and depression. It's like if you think of a teeter-totter and trying to keep it right in the middle. You know how when you were little kids and you would have one person on one side and the other person on the other side, and you would kind of keep your toes on the ground and try and keep it completely right in the middle until one of you jumped off and the other one slammed to the ground and got the wind knocked out of you. Lithium is one of the most commonly used mood stabilization medications used in the long-term care. However, it doesn't have such great side effects: weight gain, thirst, nausea, and hand tremors. Prolonged lithium use also may cause hyperthyroidism, a disorder in which the thyroid is overactive and can cause heart palpitations, nervousness, the presence of a goiter, which is like a lump on your neck, sweating, and a wide array of other symptoms and abnormalities in liver function, which, frankly, is not always appealing for people. So here's a list of medications, and for the purposes of this class, we're not going to be looking at these too intensely, but if you want to look at these in more detail, please feel free to pause the video, but I'm going to move forward now. In terms of psychotherapy, it can provide support, education, guidance to people with bipolar disorder and their families, and that's an important element. Bipolar disorder is not just about the patient, it's about the entire family unit. Some psychotherapy treatments used to treat bipolar disorder include cognitive behavioral therapy, family-focused therapy, Interpersonal and social rhythm therapy, which is designed to help people improve their mood by understanding and working with their biological and social rhythms. We all have a biological clock that we need to pay attention to, and a lot of us should keep a daily journal, and we don't have to write anything in it. We can just keep a note of how we feel on a scale of 1 to 10. 1, we feel lousy. 10, we'll feel great. Most days we'll feel 5, 6, 7. Maybe we'll have a 9. Maybe we'll have a 3. The days that we don't want to get out of bed are a 1. The days we feel fantastic is a 10. And that will help you gauge on a regular basis when we feel lousy and if there's a regular pattern to it. Then there is psychoeducation. This is an assessment of what parameters will have an impact on the outcome of our patient's disease. Implementing the boundaries and requirements of treatment. You will not go off meds, no matter how awesome you feel. Implementation of a personal cost-benefit analysis concerning specific treatment directions. Having them literally write down what happens when they go off their meds. What does it cost them? And then implementing a follow-up program and identifying future directions, which may include adjustment or change interventions. Alternative treatments, again, electroconvulsive therapy, which we talked about. And again, if someone is really desperate, this is an option. Sleep medications, because people with bipolar often have a hard time sleeping. And then keeping a life chart, recording your daily mood, the treatments, the meds you're taking, your sleep pattern, and life events, which can help you yourself and the doctors track and treat bipolar disorder most effectively. The biggest challenge with bipolar disorder is suicide. And as we've discussed in previous PowerPoints, it's a big problem with people with mental disorders. It is a major complication because it is related to the duration of the depressive episode. The longer the depressive episode lasts, the higher the risk of suicidal tendencies. Between 25 to 50% of individuals with bipolar disorder attempt suicide, and 11% complete the suicide attempt. Alcoholics and patients with other chronic medical diseases are particularly prone to planning and implementing a suicide attempt. So, if you are bipolar and you have a substance abuse problem, that is just a recipe for disaster. The 4 main groups that are likely to carry out a suicide attempt include individuals who are overwhelmed by life problems. Suicide attempts in this group tend to be related to aggression and impulsive behaviors, not significant depressive episodes. Individuals who are attempting to control others. So, for example, somebody who is married to if you are bipolar and you're married to somebody and you have spent all the money and you have had reckless sex and maybe given your partner an STD and they are leaving you because they are sick of your crap, and then you decide to turn around and say, I'm going to kill myself if you leave me. Well, you're trying to control them. And if they leave, you are either going to kill yourself or let them out of your life. So a lot of times people are willing to do that ultimate act of killing themselves just to prove that they can control it. Number 3, individuals who are chronically ill with another medical disease. And number 4, individuals with other severe types of psychotic illness, delusions, and paranoia. Okay, and then here are some of the works I have used in putting together this PowerPoint. Here's the first page and the second page. So if you have any questions, please feel free to email or text message me. I hope you have a fabulous day, and if you think that any of the disorders discussed in this PowerPoint may apply to you or someone you love, please seek help. There are emergency rooms in every town and city, and there's always somebody out there who wants to help. Thank you.